Assalamu alaikum and a very good morning to our respected seniors, dear colleagues, and residents. I'm Dr. Fareen Ashfaq, Senior Registrar at Dow Medical College, Dr. Ruth K. M. Pao Civil Hospital, Karachi. I welcome you all on behalf of my department to 25th Dermatoclinico-Pathological Conference. Before we commence our session, I would like to invite Dr. Abdul Rahim to recite few verses from the Holy Quran.
أعوذ بالله من الشيطان الرجيم بسم الله الرحمن الرحيم
Jazakallah, Dr. Rahim. Now let's begin our today's session. The theme of today's session is both timely and critical. Common skin infections with lethal outcomes. We encounter such cases in our OPD, but today we are going to explore the thin line between routine management and life-threatening complications. So moving forward with this theme, I would like to invite our first presenter, Dr. Manisha, who prepared her case under the supervision of Dr. Mavish Hassan, a consultant dermatologist.
Assalamu alaikum everyone. I'm Dr. Manisha, postgraduate trainee dermatology from Civil Hospital, Karachi. Today, I'm going to present a case of 19-year-old male patient resident of Karachi with no known comas presented to the dermatology OPD with the complaint of generalized itching all over the body for 2 months, thick crusted skin lesions and fissures for 1 month, and loose stools for 4 days. According to the patient, he was in usual state of health 2 months back when he developed mild to moderate itching at night, initially starting in the groin region, which progressively involved the axilla, hands, and then the entire body. Patient went to the local clinic multiple times for this complaint, where he was given antihistamines, antibiotic, and intramuscular injections of the dexamethasone given twice a week for 2 weeks initially, then switched to the tablet delta cortical 25 mg daily for 4 weeks. The patient didn't improve with this treatment and gradually developed thick yellowish crust over the body after 1 month, where there was fissuring over the wrist, cubital fossa, and buttocks associated with the occasional pain and no discharge. He also complains of having loose stools since the past 4 days with 4 to 5 episodes per day. The stools were yellow in color, watery in consistency, and foul smelling, containing no blood or mucus. These complaints were not associated with nausea or vomiting. He denied history of fever, weight loss, TB, or TB contact. On systemic review, my patient has shortness of breath on exertion, which according to NYHA classification was class 2. He had diarrhea and generalized malaise and the body aches on and off. Rest of the systemic review was normal. In past medical history, he has the history of use of IV and oral steroids for 2 months. No history of diabetes mellitus or hypertension. In past medical history, past surgical history was not significant. Personal history, sleep and appetite was normal. He had no addiction and bowel habits were disturbed. In family history, similar complaints of itching was found in the mother and 2 other siblings. Overall, socioeconomic history was not satisfactory. He lived in rented house and uses tap water for drinking. On general physical examination, young male patient of average height and build, confused, lying restlessly on the bed with the blood pressure of 90/50, pulse 91 beats per minute, respiratory rate 40 breaths per minute, RBS 30, and he was febrile. Patient was given ampules of 25% dextrose water state and hydrated with the 5% dextrose water, which improved his blood pressure to the 110/70, pulse 89 beats per minute, respiratory rate 33 breaths per minute, RBS 140, and he remained febrile. Throughout, oxygen saturation was 97% on room air. In subvitals, he was found to be anemic, dehydrated, and he had edema bilateral edema up to the mid shins. Now, coming towards the cutaneous examination. On examination, there was diffuse erythema with the multiple fissured hyperkeratotic plaques. These lesions were yellowish white in color with a generalized distribution, predominantly involving the buttocks and extending to the knees. Additionally, scaly plaques were noted over the bilateral upper limbs, abdomen, neck, and the posterior trunk. The plaques were firm and tender on palpation and were associated with pruritus. Nail examination revealed a shiny appearance, while the mucosal examination was normal. These are the pictures of patient showing multiple hyperkeratotic plaques predominantly over the buttocks associated with fissures. Now, systemic examination. In respiratory examination, inspection and the palpation were normal, while on auscultation, mild basal crepitation in lower lobes of the lungs bilaterally were appreciated. Cardiovascular examination, abdominal examination, and the CNS examination were normal. Keeping in mind the history and the examination of the patient, we kept in our differentials with the erythroderma secondary to crusted scabies. It could be due to secondary to psoriasis or the eczema. The red flag signs in our patient we found that was hypotension, hypoglycemia, generalized skin involvement, and edema. So we took medicine department on board and did some investigations. On hematologic findings, we found bicytopenia with the hemoglobin of 11 and the platelet count of 83,000 with the raised TLC of 15.2 and the CRP was markedly raised, that is 345. In renal profile, sodium level was low. The level of sodium was 129 and the blood urea nitrogen was 39. Liver function test also showed the affected liver with the mildly raised SGPT of 55, SGOT of 56, and decreased level of albumin to 1.6. Coagulation profile was also mildly deranged with the PT of 14.7 and the INR 1.36. Viral markers were normal, and blood culture showed the growth of MRSA and the urine culture and stool culture showed no growth. In other investigation, we did urine DR which showed proteinuria, grass hematuria along with the amorphous urates, while ASO titer, C3 level and the stool DR were normal. D-dimer was raised to 6.92 and procalcitonin was markedly raised to 24.53, which showed the severe sepsis. Morning serum cortisol was on the lower limit of the normal range, which was 4, and TSH was normal, that is 0.81, and HIV serology was not reactive. On imaging investigation, X-ray, chest, and ultrasound were normal. We did skin scraping, which shows numerous live mites on the light microscopy. I have added a short clip of the live mite under the microscope. This is the live mite. On dermoscopy, we found delta wing and contrail sign following the burrow, which confirmed the diagnosis of crusted scabies. Now, I would like to invite my supervisor, Dr. Mavish Hassan, to tell us further about this case.
Thank you, Dr. Manisha. So up till now, after a thorough history, clinical examination and relevant investigation, we can conclude that what initially appeared to be a simple
So there was a delay in onset, that is after 1 to 3 weeks of occurrence of secondary bacterial infection, these symptoms appears, which was also seen in our patient. There was absence of fever, bilateral pedal edema. The urine examination showed presence of hematuria and proteinuria. Whereas on the other hand, there were also some systemic complications which could point towards the finding that the patient might be suffering from sepsis. Now we'll be seeing what these points were. The presence of hypotension, recurrent episodes of hypoglycemia, markedly raised levels of inflammatory markers such as CRP, procalcitonin, that was also previously discussed by Dr. Manisha, and raised D-dimer levels. All of these points towards the fact that the patient might be having underlying bacteremia or might be suffering from sepsis. So to conclude, at this point, we can say that there might be a coexistence of immune and infective complications that might be seen in our patients, which initially started off with a mere skin infection that was scabies. The patient was labeled as a case of crusted scabies with systemic complications. How we proceeded and what the patient's fate was will be discussed further by Dr. Manisha.
Yes. On kiya hai.
मैंने तमास इलाज क्यों और
Meanwhile, workup was awaited. His management started with the injection ciprofloxacin 400 mg IV 12 hourly, injection metronidazole 500 mg IV 8 hourly, and he was hydrated with the normal saline with the chest auscultation. Tablet ivermectin 6 mg 3 tablets state were given, and he was advised for the melon lotion for night application, and injection human albumin 20% IV 50 ml was given state. Topical care was advised with the KMNO4, fusidic acid cream, and blend emollients. Within 24 hours of the admission, the patient's condition worsened. He developed hypotension and dropped his blood pressure to 80/50, GCS to 13/15, and on oxygen saturation was 73% on room air. Hemexil was attached, and he was taken on 5 liters of the oxygen. And an urgent call was sent to the medical ICU. Patient shifted to the ICU for close monitoring, with the plan to shift him back to the derma ward once clinically stable. In the ICU, due to his rapidly declining mental status and hemodynamic instability, he was started on injection noradrenaline support at 5 ml per hour, injection hydrocortisone 100 mg IV OD, injection meropenem 1 gram IV 8 hourly, injection vancomycin 1 gram 12 hourly, and 6 pints FFPs were transfused. After 1 day in ICU, his blood pressure support further decreased to 60/40, though on noradrenaline support, urine output decreased to 400 ml per day, TLC count raised to 21,000, and CRP raised further to 398. So the final outcome, on the 3rd day of the ICU admission, our patient expired. Because the scabies is a treatable disease and our patient died, that was very unfortunate. So we go through some literature review and we found multiple cases. One of them was reported in the JED of the 4-month-old baby who was the case of crusted scabies, and he was given steroids due to misdiagnosis and resulting in the complications and death of the baby. Another case series was reported, and large case series was reported from the Brazil and the Peru, where the bacterial infections were and as was the case with our patient.
Thank you, Dr. Manisha, for putting up such a wonderful case. Now, what was the purpose of bringing this case up at this forum? It was to discuss, could the outcome have been different, or could a young patient's fate could have been different? The answer regrettably appears to be yes, because there were several key factors that had been delayed or mismanaged during the treatment or during the management of the patient. Initially, to look back, what happened was that the patient was, although rightly diagnosed as a case of cutaneous infestation, that is scabies, but it was not rightly, or there was delay in diagnosis of the systemic complications or the complication that is associated with the infestation of the mite or scabies. That resulted in delayed diagnosis or delayed pickup of the complications. Along with that, there was inappropriate initial treatment. As Dr. Manisha told, that initially the patient was given, along with the treatment for scabies, he was also advised steroids. So it also aggravated the systemic complications, and we need to shed light why there was unnecessary or injudicious use of steroids. Failure to recognize early warning signs of sepsis that has been previously discussed, that were the red flag signs that one has to keep an eye on when you are looking at the patients during your OPD. And what those signs are were the presence of recurrent episodes of hypotension, hypoglycemia, complaints of fever, malaise, and body aches, presence of bilateral pedal edema. All of these led to lack of timely escalation of care and referral to a proper tertiary care setup, where the patient could have been provided with proper management by the dermatologist, people from the medicine department, and also nephrology. This case serves as a sobering reminder that even a simple treatable skin condition such as scabies can become life-threatening when mismanaged and inappropriately treated. Hence, early recognition, timely intervention, and clinical vigilance remains the cornerstone of patients' management. Thank you.
Thank you, Dr. Manisha and Dr. Mavish, for nicely presented case. Now, moving towards our next presentation, I would like to invite Dr. Abdul Rahim, who prepared his case under the supervision of Dr. Alina Ahmed, who is Senior Registrar at Dow Medical College. Dr. Abdul Rahim.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum and good morning. I am Dr. Abdul Rahim, postgraduate trainee, Dermatology Department, Civil Hospital, Karachi. My case for today is a 45-year-old female, married, resident of Herpes, housewife, came through emergency department in Civil Hospital. With the presenting complaints of severe headaches, and erythematous swelling on face and eyelid, and crusted lesions on face and scalp for the last 6 days. History of presenting complaints. According to my patient, she was in her usual state of health 6 days back when she first developed pain on left side of forehead, radiating down the left side of face and nose, accompanied by a fluid-filled vesicular rash on left side. The pain increased in intensity and changed into severe continuous burning pain, non-responsive to paracetamol and NSAIDs. For these complaints, she went to a tertiary care hospital in her village, where she was treated as some infection with injections ceftriaxone and gentamicin. Despite treatment, she noticed a rapid worsening of her symptoms and developed marked swelling of left eye, accompanied with watery discharge. She also reported a flu-like illness with low-grade fever, body ache, and malaise for the last 1 week. She had been advised CT brain, which was not significant for any obvious pathology. Her condition did not improve, and she was referred to Civil Hospital, Karachi for further management. On detailed systemic review, she presented with severe unilateral headache, while rest of cardiovascular system, respiratory, genitourinary, abdominal, and musculoskeletal system review was unremarkable. In past medical history, no prior history of diabetes mellitus, hypertension, or TB. Cholecystectomy was done 10 years ago. No history of any oral, topical, or injectable drugs. No history of any chronic illness present in the family. On personal history, sleep was disturbed, appetite was decreased, while bowel habits and micturition was normal, and no history of addiction or allergy was present. Socioeconomic history was satisfactory, while transfusion history was not significant. On physical examination, an ill-looking middle-aged female of average height and slightly overweight, oriented to time, place, and person, with the vitals of 138 by 78 millimeters of mercury, with the pulse of 83 beats per minute and respiratory rates of 23 breaths per minute, while patient was afebrile at the time of examination. On cutaneous examination, grouped papules and vesicles with few hemorrhagic blisters on an edematous base over the left side of forehead, extending down to involve the left periorbital area, left side of nose, left nasal ala, and tip of nose, which showed Hutchinson's sign was positive. Both upper and lower eyelids of left eye were grossly swollen. The skin manifestations were not crossing the midline along the distribution of ophthalmic branch of trigeminal nerve. Intraoral examination revealed erythema and ulceration of the ipsilateral hard palate and buccal mucosa. Here we can see in the first picture, which was taken by the patient in her village, while the second picture was taken by our medical team when she landed in our emergency department. As we can appreciate, hemorrhagic blisters and crusting over the left side of forehead and tip of nose, not crossing the midline. Here we can see the oral cavity, the first picture, which is showing the mucosal ulcerations of the anterior two-thirds of hard palate with a black patch only towards the left side. While in the second picture, we can see the upper gingival mucosal ulcerations also present on the left side. On detailed systemic examination, cardiovascular examination, respiratory examination, abdominal examination were all normal, unremarkable. While extensive neurological examination of all the cranial nerves could not be carried out due to the severe pain. However, limited examination of cranial nerves 3, 4, and 6 did not show any ophthalmoplegia. On laboratory investigations, hemoglobin, total leukocyte count, and platelet counts were all within the normal limits. While her CRP was increased to 41 milligram per deciliter, and her HbA1c was 6.1% with no prior history of diabetes mellitus. Her liver function test, renal function test, and electrolytes were all within the normal limits. Other laboratory investigations like thyroid profile, serum cortisol levels were also normal. Viral markers were non-reactive. Urine DR was normal, while her cultures like blood culture, urine culture, and pus culture show no growth of any pathogens. On imaging investigations, chest X-ray and abdominal ultrasound showed no abnormality and no visceromegaly. So we keep our differential diagnosis as herpes zoster, insect bite reaction, cellulitis, and mucormycosis was kept down the list due to the presence of black necrotic patch on hard palate. So we did zinc smear, which was performed from vesicular fluid, which showed multinucleated giant cells. So our final diagnosis was made, which was herpes zoster ophthalmicus with multidermatomal involvement. So this was our final diagnosis. So we started aggressive treatment in our ward with the injection acyclovir 500 mg IV 8 hourly, injection meropenem 1 gram IV 8 hourly, and injection hydrocortisone 100 mg 12 hourly. While ophthalmology, ENT, and neurology team was taken on board, tablet pregabalin 50 mg BD was started for the severe pain, and ocular and cutaneous topical care was advised to the patient. So this is the picture which was taken at the time of discharge. After time of discharge, after the 14 days of antiviral therapy, as we can see residual scars which were present on left side of the face due to the deep-seated lesions. The patient is in continuous follow-up with our department. Now, I would like to invite our senior registrar and my supervisor for this case, Dr. Alina, to further highlight the importance of this case and this clinical picture. Thank you very much.
Assalamu alaikum. Thank you, Dr. Rahim, for the interesting case presentation. I'll take it from here. So, what are the key learning objectives because of which this case was brought here to the CPC? This was a case of common disease with an unusual severity, and whereas Hutchinson's sign was positive from the start, which is the clinical predictor of severe ocular involvement, along with early neuropathic pain, which itself gave a diagnostic clue, but still there was initial mismanagement and diagnostic delay, which led to a vision-threatening emergency. On literature search, even though we found cases of multidermatomal herpes zoster involvement, but they were all associated with severe immunosuppression or of elderly patients who were suffering from HIV or some malignancy or were on chemotherapy. And to the best of our knowledge, no case has been reported before in Pakistan of a multidermatomal herpes zoster ophthalmicus in a previously healthy, immunocompetent patient. I've included this slide for the better understanding of our residents and students to demarcate clearly the distribution of the three branches of trigeminal nerve. As you can see, the ophthalmic, maxillary, and mandibular nerve distribution. And in our patient, the left half of the forehead, periorbital area, bridge of the nose, and tip of the nose, all included in the ophthalmic nerve distribution were involved. Other than that, the temple area, the cheek area, and the upper gingival mucosa are covered by the maxillary nerve or V2 branch of trigeminal nerve. In this slide, you can clearly appreciate the oral mucosal distribution. You have to note that V1 or the ophthalmic division of the trigeminal nerve has no intraoral mucosal involvement, whereas V2 or maxillary branch covers the upper gingiva, hard palate, posterior 1/3 of the nasal septum, and the lower gingiva, floor of the mouth, and anterior 2/3 of the tongue are covered by the V3 or mandibular branch of the ophthalmic nerve. Is my voice clear? So the red flags in such cases, that is severe neuropathic pain, Hutchinson sign positive, severe eye pain, and in cases of immunosuppression, if there are any, it warrants immediate action. On literature review, we found a similar case to our case, but of an elderly man of a 71-year-old patient. This was published in the BMC Dermatology Journal, and this was a 71-year-old patient who was previously healthy and immunocompetent, and the lesion, similar to our case, developed on the left side of the forehead, nasal bridge, and tip of the nose, along with the hard and soft palate involvement and the nasal columella, which is along the distribution of the ophthalmic as well as the maxillary branch of trigeminal nerve. The patient was promptly started on IV antiviral therapy, and the patient responded with a rapid recovery. The take-home message of this case is that multidermatomal herpes zoster ophthalmicus is a red flag presentation requiring urgent recognition. Hutchinson sign is a key predictor of ocular complications and must not be missed. Early initiation of appropriate antivirals are crucial to prevent the disease progression, and misdiagnosis and treatment delay often can result in avoidable morbidity. So think early, treat early, and refer early to preserve vision and for a good outcome. Thank you very much.
Thank you, Dr. Alina and Dr. Rahim, for enlightening case. Now, moving towards our last presentation, I would like to invite Dr. Aisha, who prepared her case under the supervision of Senior Registrar Dr. Neha Rana.
Assalamu alaikum and good morning, everyone. My name is Dr. Aisha Koon Sheikh, and I'm postgraduate trainee in Department of Dermatology in Civil Hospital, Karachi. Today, I'll be presenting a very interesting case. Our patient was a 55-year-old female resident of Karachi, married, housewife, came via OPD with complaint of generalized body rash with itching from last 2 months and swelling of the face and legs from last 1 week. According to the patient, she was in her usual state of health about 6 months back when she first developed erythematous ring-shaped lesions over the abdomen. Lesions were associated with itching, gradually increase in size and number, spreading to involve almost entire body surface area. For these complaints, she went to a local clinic where she was prescribed oral and topical potent steroids for the relief of the symptoms. She was also given intravenous and intramuscular steroids on and off for approximately 4 weeks. Despite treatment, she noticed rapid worsening of her skin lesions and she developed generalized erythema with extensive scaling. Over the last 1 week, she also complained of progressive swelling of lower limbs, which later extended to involve face and above, leading to generalized edema. She also experienced generalized weakness, easy fatigability, and loss of appetite. And there was no history of fever, oral ulcers, or joint pain and photosensitivity. On systemic review, patient had history of diarrhea 3 episodes per day, which were watery in consistency, with no history of abdominal pain, nausea, or vomiting. However, patient's CVS, CNS, respiratory, genitourinary, and musculoskeletal reviews were unremarkable. On past medical and surgical history, patient was known case of diabetes and hypertension, and there was no any prior history of TB, hepatitis, renal disease, or connective tissue disorders. On drug history, patient had multiple courses of oral, topical, and injectable steroids for a skin complaint, which were self-medicated and prescribed. On family history, patient's husband and multiple family members had history of tinea infections in the past. On personal history, she had normal sleep, normal appetite, her bowel habits were diarrheal, her appetite was decreased, and there were no any history of addictions in the past. Patient's allergic and transfusion histories were non-significant, and socioeconomic history was satisfactory. On physical examination, my patient was an ill-looking middle-aged female of average height and slightly overweight, was oriented and awake. Patient's vital at the time of examination were blood pressure 122/77, temperature afebrile, pulse 107 beats per minute, and respiratory rate of 22 breaths per minute. In subvitals, she was anemic, dehydrated, and there was bilateral pedal edema, which was pitting in nature, with no jaundice, clubbing, cyanosis, chylonychia, or palpable lymph nodes. On cutaneous examination, patient had generalized erythema with mild scaling involving almost entire body surface area, most marked over the trunk and extremities. At some places, annular plaques with scaly raised borders on the trunk were also noted. Patient's face showed generalized erythema with puffiness, and abdominal striae were also appreciated. On systemic examination, patient's cardiovascular, respiratory, GIT, and CNS examination were all unremarkable. On further investigation, patient CBC showed HB of 9.7, TLC 9.1, ESR was elevated to 40, and CRP was raised to 248. On liver function test, patient's liver function tests were normal with low albumin of 2.0. Patient renal function test and electrolytes showed hyponatremia with sodium value of 132 and hypocalcemia with calcium value of 5.1. On further evaluation, patient's chest X-ray was normal and ultrasound abdomen showed hepatomegaly with fatty infiltration. On other laboratory investigations, patient's 8 AM serum cortisol was performed, which turned out to be very low with value of 0.97, as the normal value ranges from 4.82 to 19.5. And patient's HbA1c was also raised to 10.38. So our final diagnosis on the basis of history, examination, and laboratory investigation was tinea incognito associated with iatrogenic Cushing syndrome. From here, I would like to invite my supervisor, Dr. Neha, to please come forward and discuss this.
Assalamu alaikum and good morning, everybody. I am Dr. Neha Rana, Senior Registrar Dermatology. Here, I will be discussing about what is iatrogenic Cushing syndrome. It is one of the most common causes of Cushing syndrome, and it is caused by prolonged use of exogenous glucocorticoids. What really happens is that the hypothalamus releases CRH that signals the anterior pituitary to release ACTH, and ACTH signals the adrenal cortex to start releasing cortisol. So when the patient is given exogenous glucocorticoids, which might be of any form, it could be intravascular, intramuscular, or topical, that results in the as a result of which the adrenal cortex is not producing cortisol, because the hypothalamus and the anterior pituitary, they're not signaled to produce cortisol, and the body is dependent upon on the exogenous form of corticosteroids. So patient presents with a range of features of Cushing syndrome that range from certain cutaneous manifestations, and then there are certain systemic manifestations. The cutaneous manifestations include thinning of hair, extra face and body hair, red cheeks, and moon faces. And also there are thin skin, easy bruisability, ecchymosis, fat pad, and buffalo hump. Patient also presents with hypertension, diabetes mellitus, osteoporosis, and poor wound healing. So as discussed previously, that with exogenous glucocorticoids, the hypothalamus is not producing CRH, ACTH, and the adrenal cortex is not producing cortex. So what really happens with the chronic use of cortisol, there is hypothalamic pituitary adrenal excess suppression. Normally, the study suggests that the physiological cortisol production is 5 to 7 milligram per day. And with patients are considered to be adrenally suppressed if they are taking more than 20 milligram per day of prednisone or equivalent for more than 3 weeks, more than 50 grams of super potent steroid or 100 grams of potent steroid, or patients with signs of Cushing syndrome. And these patients must be provided with medic alert bracelet and an information card detailing their diagnosis. Can you hear me now? Updated medication doses and stress dosing instruction. Further, Dr. Aisha will discuss the course of the patient.
On the second day of admission, patient's condition further deteriorated and her vitals were her blood pressure dropped to 81/63. Patient became tachycardic with pulse rate of 130 and tachypneic with respiratory rate of 32. Her RBS was 77. Patient's laboratory investigation showed HB 9.7, TLC raised to 14, platelets dropped to 121, BUN raised to 26, creatinine raised to 2.1. Patient was still hyponatremic with sodium value of 126, and this time she also became hyperkalemic with potassium value of 5.3. Patient's FBGs were also performed which showed metabolic acidosis. So clinical suspicion of adrenal crisis was met and patient was shifted to medical ICU due to the high risk of hemodynamic collapse. Adrenal crisis, it is mostly precipitated by any trauma, infection, or surgery, which cause suppression over the adrenal medulla, causing decreased release of aldosterone and cortisol, which can be life-threatening and can cause refractory hypertension to IV fillers and vasopressors, and can cause vomiting, nausea, abdominal pain, alter mental status, hyper or hyponatremia, and shock. And laboratory investigations can also show hyponatremia, hyperkalemia, metabolic acidosis, and hypoglycemia. And this condition is mostly managed with normal saline and IV or IM glucocorticoid injections. Management in medical ICU, patient was given hydrocortisone 100 mg IV bolus followed by 50 mg IV 6-RD. Patient was also started on broad spectrum antibiotics as vancomycin and meropenem. Patient was started on inotropic support, noradrenaline for low BP, and she was intubated. Patient was also advised topical wound and skin care, fillet and electrolyte monitoring, nutritional and albumin support. Course in medical ICU. Patient developed sepsis with worsening renal failure and hemodynamic instability. Patient's vital blood pressure further dropped to 77/57 despite on inotropic support. She was still tachycardic, tachypneic. This time her GCS also dropped to 11/15. On laboratory investigation, patient TLC further raised to 26. This time her LFTs also became deranged with total bilirubin level of 2.7 and SGPT of 242. Patient BUN and creatinine was also on higher side, her sodium was on lower side, and FBGs still showed metabolic acidosis. So despite aggressive management, patient sadly passed away on day 7 of admission. From here, I would like to invite Dr. Neha to hand over this case.
Thank you, Dr. Aisha. I'll take it from here. So why we brought this case today? It is because what began as a simple superficial cutaneous fungal infection resulted in multi-organ failure and sadly a loss of life. It all because of inappropriate prescription and easy accessibility of steroids that resulted in widespread infection, sepsis, and ultimately life-threatening sequelae like adrenal crisis. Here, I would also like to share few inpatient cases with you. So these two patients had tinea incognito associated with iatrogenic Cushing syndrome, having tinea infection for 6 to 7 months and 1 year respectively. Now, these patients were given all forms of topical steroids, injectable steroids, and also our first case was giving azathioprine for this tinea infection, and our second case was given methotrexate for this on in our part of the world. So these patients had very low serum cortisol. And lastly, for the last case, especially I would like to bring your attention to this case because she was just a 17-year-old teenage girl who had tinea infection for the past 8 years. So this patient is a 17-year-old teenage girl who had this tinea infection for the past 8 years, and she was given all forms of steroids, including topical and injectables. This patient hadn't achieved her menarche yet, and she's primary amenorrheic. Furthermore, she had hirsutism, she had generalized swelling. So she's not having just the tinea infection and iatrogenic Cushing syndrome. She's also having the psychological impact of all the self-prescribed and the inappropriate prescription of topical steroids that she has been given for a very simple infection, which is tinea. Her serum 8 AM cortisol was significantly low, which was 0.09. Here, I'll complete the case for you all. So yes, there is an alarming increase in the cases of tinea incognito associated with iatrogenic Cushing syndrome, which is due to the unnecessary steroid use, which must be strongly discouraged. Also, it's very important to educate all the healthcare professionals, starting from the undergraduate level, for the accurate diagnosis and appropriate treatment of tinea infection that needs to be prioritized at all levels. And it's very important to make the healthcare professional, starting from our fourth-year students, to make them aware for the early recognition of steroid-related complications with timely referrals that are essential to prevent serious harm and to save lives. These were our references. That's all from our side. Thank you very much.
This concludes our today's session. Now, I would like to request our Honorable Head of Department and Professor Dr. Mehra Talat to give her expertise and valuable comments regarding today's session. Dr. Mehra Talat.
Assalamu alaikum everyone and a very good morning. First of all, I am very thankful to the young generation of our department that they have presented very well all the three cases, and all the seniors, including Dr. Mavish, Dr. Alina and Dr. Neha. They helped them to prepare their cases. And I would highlight that all the three cases presented today highlighted that how dermatology is directly or indirectly connected to medicine. That's why in order to have good know-how of dermatology, we need to learn medicine also. And if all these cases if all these cases, these were the common presentations and all the cases were treatable. If left untreated, they may have fatal outcome. This is the message that we want to convey to all of you from this inter-hospital meeting. And I think we have played our role. And what are your comments? You can give your comments online also, and you can write in the chat box also. So any comment, any question from our supervisors? Any comment if our seniors are listening? So with this, we would like to end to our session. Thank you very much. Antifungals, along with tapering of the steroids if your patient is on a steroid. You have to taper down injectables, and you have to taper down oral, and even you have to taper down the topical steroids. Fungal infections are very much resistant and challenging nowadays. Thank you.